Herpangina represents a significant viral infectious disease predominantly affecting the pediatric population, particularly children under 10 years of age. The etiological agents responsible are primarily enteroviruses, with Coxsackievirus A virus being the predominant pathogen. This self-limiting condition typically resolves within 7 to 10 days post-onset. The virus demonstrates high transmissibility through multiple routes, including respiratory droplets, salivary contact, and fecal-oral transmission, making it particularly prevalent in communal childcare settings. Clinical presentation. The disease manifests with an acute onset characterized by several prodromal symptoms. Patients typically present with pyrexia, often accompanied by significant pharyngitis, headache, and marked anorexia. The pathognomonic feature develops within 24 to 48 hours of initial symptomatology, presenting as distinctive vesicular lesions. These lesions initially appear as small, grayish-white vesicles that rapidly progress to form shallow ulcerations. The distribution of these lesions is characteristically concentrated on the soft palate, tonsillar pillars, and uvula, with individual lesions rarely exceeding 5 millimeters in diameter. In the pediatric population, additional manifestations often include marked irritability, excessive drooling, and painful swallowing, which can significantly impact oral intake. Hand-foot-mouth disease. Herpangina and hand, foot, and mouth disease are both illnesses that are caused by the Coxsackie virus. Herpangina causes ulcers at the back of the mouth. Hand, foot, and mouth disease causes blisters on any combination of the hands, feet, and the mouth. Both herpangina and hand, foot, and mouth disease can start with fever, sore throat, and generally not feeling well for several days before the small red spots appear. Children may not want to eat and may become very irritable. Older children may complain of headache, sore throat, and lack of energy. Diagnosis. The diagnostic approach to herpangina is predominantly clinical, relying on a comprehensive synthesis of presenting symptoms, thorough physical examination, and recognition of the characteristic oropharyngeal lesions. Laboratory investigations are generally not indicated for routine diagnosis. However, clinicians must maintain a high index of suspicion for differential diagnoses, particularly herpetic gingivostomatitis and hand-foot-mouth disease, which may present with similar oropharyngeal manifestations. The distinction between these entities is crucial for appropriate patient management and prognostication. Management. The therapeutic approach to herpangina focuses on supportive care, as no specific antiviral therapy has demonstrated efficacy. The cornerstone of management includes appropriate antipyretic and analgesic therapy, typically employing acetaminophen or ibuprofen to address both pyrexia and odynophagia. Ensuring adequate hydration is paramount, particularly given the potential for decreased oral intake due to dysphagia. Dietary modifications should focus on soft, non-irritating foods to minimize discomfort during ingestion. Regular oral hygiene, supplemented with saline rinses, can provide symptomatic relief and potentially reduce the risk of secondary bacterial infection. Complications. While herpangina typically follows a benign course, clinicians must remain vigilant for potential complications. The most common complication of herpangina or hand, foot, and mouth disease is dehydration. Children may refuse to drink fluids due to the pain in their mouth or throat. However, with care at home, most children can get enough liquids to stay hydrated. Febrile seizures may occur in susceptible children due to the rapid onset of high fever. CNS complications. In rare instances, particularly with Enterovirus 71 infections, neurological complications may develop, including meningitis, encephalitis, and acute flaccid paralysis. These neurological sequelae, though uncommon, necessitate prompt recognition and appropriate intervention when present. Myoclonic jerk is an early sign of central nervous system involvement, especially in young children. Among the hand-foot-mouth disease etiologic agents, Enterovirus 71 is the most pathogenic and more frequently associated with complications extending to the CNS, such as brainstem encephalitis. Other early signs related to CNS complications include lethargy, agitation or irritability, truncal ataxia, and rotary eye movement without fixation. Prevention strategies. Effective prevention of Herpangina transmission relies on implementing comprehensive infection control measures. Emphasis should be placed on proper hand hygiene, with thorough hand washing for a minimum of 20 seconds being essential. Appropriate respiratory etiquette should be encouraged, along with regular disinfection of potentially contaminated surfaces. Given the high transmissibility of the causative viruses, isolation of infected individuals until resolution of fever is crucial in preventing outbreak scenarios, particularly in educational or child care settings. Patient education. Effective patient education is crucial for optimal management of Herpangina. Healthcare providers should emphasize the typically self-limiting nature of the illness while providing comprehensive guidance on symptom management techniques. Detailed instruction on proper hygiene practices is essential to prevent transmission to close contacts. Patients and caregivers should be thoroughly counseled on red flag symptoms that warrant immediate medical attention, including signs of dehydration, persistent high fever, or any deterioration in clinical status. This education empowers patients and caregivers to participate actively in the management process while ensuring timely recognition of potential complications. Clinical pearls. In the clinical management of Herpangina, several key points warrant emphasis. The highly contagious nature of the causative viruses, particularly in pediatric settings, necessitates appropriate infection control measures. Clinicians should be aware that viral shedding may persist for weeks following symptom resolution, emphasizing the importance of continued precautions. The primary focus of clinical management should be preventing dehydration and effectively managing patient discomfort. Early recognition of the condition facilitates appropriate patient counseling and management, ultimately optimizing outcomes. Healthcare providers should maintain a high index of suspicion for potential complications while generally reassuring patients about the typically benign course of the illness.
Thank you for watching. Please subscribe to our channel by clicking the subscription button. If you have any questions, feel free to leave a comment below in the comments section.